We are live, Thomas. Please take the floor.
Great. Well, welcome to this third year in a row State of CareOps report. Super excited. Also excited, Rick, that we're able to do this every year in a row, besides all of the other priorities. So really happy to have Tony and Nate on the webinar today. We'll ask you to introduce yourselves in a minute formally, but we have the habit to ask an icebreaker question. So I relocated my family to the States earlier this year, and they're all fired up about Halloween. So my question is, what is the Halloween suit you will be putting on in a couple of weeks? Nate, why don't you go first?
I have not been dressing up for Halloween the last few years, and my family has been giving me a hard time about it, and they've been really pushing me to decide what I'm gonna wear this year. I'm a big fan of the Talking Heads and David Byrne, and so the thing they all want me to wear is like, do you know this is the card they gave me for my birthday. Do you know the big suit that David Byrne wore in his concert performances? That's what they want me to dress up as. So we'll see if that happens.
Nice, Tony.
Yeah, that's a good question. I generally don't dress up. It's been a number of years. I have a cape that I'll put on just to get a little festive when kids come around to give out candy. I'm deep in helping my son put together his Halloween costume. He and his group of friends have decided to be breakfast cereal characters. If you're familiar with breakfast cereal characters, someone is Captain Crunch. My son ends up as Count Chocula, and so we're trying to put together a Count Chocula, the chocolate vampire costume, piecing it together from things from Amazon. It's not easy to find a brown vampire cape, but we're working on it right now. So
Cool, amazing. Rick, what about you?
I will go as an AI founder. So I have a briefcase full of cash with a label 100 million seat round, and then a tablet with coming soon, and this is only the beginning.
That's good.
So I'm going to go as broccoli because kids these days are not scared anymore of skeletons and all of the classic Halloween things, but I decided, to go as one of the vegetables. We'll see what reactions are. And it's in line with the CareOps colors. So let's get started. State of CareOps report 2024. We'd first like to introduce the panel to the people in the room. So we'll go in the same order. Nathan, Tony, if you could tell us who you are, where you work, also where you worked previously, what excites you about CareOps?
Sure. So I'm Nate Favini. I'm the Chief Medical Officer at a company called Pear Team. I'm a general internist, primary care doc by training. I've probably been thinking about CareOps for most of my life. I grew up in a rural part of the country. My dad's an emergency physician, and I grew up hearing all these stories from my dad about people who ended up in the emergency department much sicker than they should have been because they didn't have good primary care, didn't have good preventive care. And so apparently from like the age of 7 or something, I've been telling people I wanted to be a primary care doctor and try to fix our healthcare system. And so that's probably where my CareOps journey started. I had a very formative experience where I was a Peace Corps volunteer after college, and I saw the mobile phone revolution play out in this little town in Mozambique where I was a high school biology teacher. And I think that seeded in my mind the idea that if you built the right tools, you could leapfrog the existing ways of doing things and get products and services to people who didn't have them. And so those two experiences, I think, are why I ended up in digital health and working on things related to CareOps. The company I work at today is called Pear Team. We're a value-based care provider in Medicaid, and we're really trying to bring innovation to the Medicaid space where I think there has not been enough focus on innovation. We really got our start here in California. There's a new benefit here as part of our Medicaid waiver called enhanced care management. And we do a really intensive intervention, including case managers, nurses, behavioral health professionals, nurse practitioners, for the 5 to 10% of Medicaid beneficiaries who are most complex from a medical and social point of view, and really focus on getting them better care, helping them stay out of the emergency department, stay out of the hospital, improve their health overall. And we have great outcomes in terms of reductions in acute care utilization and improvements in measures of diabetes, blood pressure, depression control, and all those types of things. And CareOps is a big part of how we do all of that.
Cool, thanks,
Great,
Nate.
thanks, Nate. Tony?
Yeah, and thanks for having me, Rick and Thomas. I'm super excited to join the conversation. I'm Tony, physical therapist by profession. I have over 20 years of experience in healthcare. The majority of my time has been spent in home and community-based services, where I typically have worked on some way of driving meaningful human connection in the home, I guess you could say, is usually the point and the purpose. I've spent the last 14 years at Bayada Home Healthcare, where I started as a field physical therapist, treating patients in their homes, worked my way through a variety of different roles. Currently, SVP of Clinical Strategy, Innovation, and Care Delivery. Essentially, I'm like the chief clinical officer for home health, responsible for our clinical and quality support team, clinical informatics, strategy and project management, as well as what we call shared services, which are like revenue cycle functions, diagnosis coding, billing, automated functions, RPA, different outsourced functions as well. If you're not familiar with Bayada, we're the nation's largest nonprofit provider of home and community-based services. We are hitting our 50th year as an organization, 8 different service lines, 23 states. I primarily work with our Medicare certified home health service, which for those that are not familiar, it's a usually short-term post-acute nursing and therapy-based service in the home. Therapy meaning physical, speech, or occupational therapy in the home. Highly distributed workforce. We have a patient census of about 30,000 patients right now across the country. We're also, I think, a little bit unique that we have a digital product team as well, which we'll talk about more as we go along, but partnering internally, not just with care delivery, but with the product team. And so on a personal note, I spent a year leading a product team in the analytics space. I had product managers, engineers, data analysts, a variety of different employees working towards creating like data solutions for value-based contracting, quality outcomes, risk-based care. And so I think I'm, by the physical therapist background, I always like to identify issues and fix them. It's kind of like how we're trained as PTs, identify the dysfunction, identify the driving factors and see if you can come up, sort of test and come up with different solutions. And it's the same thing with care delivery at a large scale. So happy to be here.
Yeah, that goes right to the heart of CareOps. Great. Love the expertise on the panel. Rick?
Yep, nurse. I'm a nurse. Nurse by training. Always thought that I would become an oncology nurse. Then I met Thomas and I joined Awell, where I now lead clinical strategy. So essentially, what we do with Awell is we're building the CareOps platform that allows care organizations to design and continuously improve their care processes. And what I do is I sit together with the clinical leaders, the nurses, the doctors, the providers in general. I look at their workflows and then I figure out how can we streamline that using our technology. So it's a lot of implementation, a lot of change management, and a lot of thinking. How can we drive continuous improvement at scale without burning out the clinical team? And that's what I think about day and night. So that's fun.
Thanks. So I'm Thomas, co-founder, CEO at Awell, and I'm also co-author at CareOps together with Rick. Let's get started. The State of CareOps report, as usual, will be published on our website, on careops.org. It's actually already there. We'll link to it at the end of the presentation. We put together some of the insights in a deck that we will use to go through the conversation today. And so the first insight that we want to talk about is the actual use of care flows. So what the report shows is that there's an overwhelming use of care flows in the organizations that were surveyed. Now, Tony, in the prep leading up to our conversation today, you mentioned that there's actually a pretty big difference between the actual universal, consistent, enforceable, and trackable use of a care flow. So those are the exact words that you used, versus maybe training a care team on a PDF, then printing it and hanging it up on the wall in the cafeteria, right? So those are two sides of the spectrum. So I'd love to dive a little bit deeper into this definition of use. Specifically, how would you both at your organizations define, using a care flow in practice?
I can follow up on that comment, Thomas, as you mentioned, like there's probably a broad spectrum of what we mean by using care flows, right? You can develop something, it can be on an Excel sheet or on a PowerPoint, and you deploy it to your teams, and here you go, here's the care flow, here's the process flow, go do it, right? But I think the heart of what we'll talk about a lot today is if the driving factor in your care flow is relying on someone to remember to do something, right? If the success of your care flow is relying on someone to just remember to do something, then you're probably going to have a high level of variation and maybe not be as successful as opposed to an actual, whether it's an EMR-driven process or a separate system or some way of tracking and training that it actually gets deployed into practice. It's all using care flows, but I think there's various ways of actually determining successful deployment of care flows.
So what you're saying there, Tony, is that we overestimate the capacity of the human brain to remember things.
Well, I'm saying we give people too much to remember sometimes, especially from the clinical standpoint and frontline staff.
Yeah. Nate, how about you?
There's probably some threshold at which something becomes a care flow. And it's a question of where you draw that line. Like clearly someone looking up a flow chart on UpToDate on their own and then deciding what to do for the individual patient in front of them. I don't think any of us would call that a care flow because it's not organizationally defined, and it doesn't serve like a larger care goal of the organization. That's a clinician making an individual decision based on a flow chart that's recommended by experts. On the other end of the spectrum, you've got, software that drives flows through the organization, including clinical decision making. And I think on that end of the spectrum, yes, we'd all say, yes, that counts as a care flow within your organization. And then there's this amorphous space in between. And like, where does it hit the threshold of actually being a care flow? And to me, it's like, the key thing is it organizationally defined? Has it been aligned upon by like multiple stakeholders at the company, and is it serving like a broader company goal, which could be quality, it could be revenue, it could be, there's a number of things that it could be driving. But if it's not a process that's aligned upon that you've pushed to your clinical teams in order to achieve a specific goal, then it's probably not a care flow.
Yeah, great. That's actually the perfect segue into the next insight. And so we're organizing this conversation as well as the report along the different stages of the CareOps life cycle. And so, the first stage is ultimately, design. And so you have that concept of organizationally defined. I like that, Nate. And so bringing the necessary roles together to be able to define these care flows is a prerequisite to proper implementation later on, and to be that, to meet that organizationally defined threshold. So what we're seeing in the report is that 36% of respondents include what we have dubbed the 4 CareOps roles, which is clinical operations, clinicians, product managers, and software engineering in the design phase of their flows, and that's up from 16% in 2023. So question for both of you. So that means that 64% have a barrier to work cross-functionally or are not, bringing in these necessary roles. So what at your organizations have you done practically to overcome those hurdles? Maybe you can touch also upon, the additional roles that you have in your teams to make sure that you reach this notion of organizationally defined and an alignment between the different roles. Maybe Nate, you can go first.
Sure. The first thing that jumps out at me is the organizations who take the CareOps survey must be on the innovative tech leaning end of the spectrum, because so many of them have product managers. And I just don't think that's a concept that's like really been taken up very much in the traditional healthcare system. And so I think it's reflective of like who's thinking about things this way and who's on the leading edge of this. I agree, those are the 4 key roles, and we in multiple companies I've worked at, we've really tried to create a sort of pod-like structure to make sure that the right collaboration is happening across those functions. So like when you're kicking off a project, there should be an operations person, a clinical person, a PM, and a software engineer who are working on the project. The clinicians are often the hardest to get because they have so many other responsibilities day to day with taking care of patients. And you can solve that either by having clinicians in dedicated roles who do this specifically, or by making time for your clinicians who are practicing day to day to participate in these types of activities too. And we've called those folks clinical champions or something along those lines to help define the role and get them involved in that. Software engineers are, I think, we're maybe the lowest on the list of your core four, and it's probably because like a smaller number of organizations are doing the development of the software in-house, right? But if you really want to drive the outcomes on these things, you need to have a tool that supports it, and so you're going to have a PM or a software engineer involved in this stuff, and then the one role, I'm trying to think if there are others, but one role that wasn't on the slide that came to mind that can be an important part in this is legal, because sometimes you're wondering, like, can I do the care flow this way? Is it okay to engage the clinician in the workflow in this manner? And you rely on legal input for that. But I think the key is like having some sort of like an institutional notion of that pod being important and bringing those people together around a project.
And so what you're saying is essentially whenever you design a care flow, let's say for diabetes, then you create like a group of people that already includes the necessary roles in order to create that, to push that cross-functional work instead of like working in the typical silos. Clinical operation design something first, then they discuss it with product. So you say, no, don't do that. Just start from a pot and go from there instead of working in silos, which I think makes a lot of sense.
Yeah, if you've agreed that this thing is important for the company and driving this forward, like you should dedicate the resourcing to it and kick off a project that includes people from all of these backgrounds. And now people may need different levels of involvement based on the stage of the product. The software engineer may not need to be as engaged at the outset, but needs to be much more engaged later on. But I think you want to define these resources and bring people together around the goal at the outset.
Yep. Anthony, what about you? Like Bayada is obviously is a total different scale as most organizations. So how are you facilitating that cross-functional collaboration when it comes to designing new care processes or flows?
Yeah, I think what is sort of unique for us among home-based care providers is that we do have a product team, a digital product team, which is relatively new. I don't think you'll find it in a lot of home care providers. It's really within the last 2 years that we've stood up this digital product team, which we think about it in two ways, like the service delivery itself as a product, right? And so what's the user journey? What are the user requirements? What kind of enhancements do we want to make to the total package of services? But also you could think about subcomponents of the service as products themselves too. So the team that's dedicated to home health, I think, has helped us to evaluate, integrate, and optimize different digital solutions, whether it's different SaaS products that are out there, whether we build something in-house and acting like a connector for us, where the clinical and care delivery team might know that we need to enhance our care delivery for patients with heart failure, or we might need to expedite some of the data collection around a certain outcome measure, where we might grasp the KPI, the result, the current state, but might not realize the range of different solutions that could be out there. And so having that product mindset helps to connect the care delivery and quality teams to the IT infrastructure, whether that's the information security, whether it's legal, like Nate was just talking about, things that we might not initially be considering, data solutions, where do we store the information, where do we pull it from, application management, just as simple as like, we want to add a tool that prompts our clinicians for certain high-risk patients that does risk stratification, right? But it's a separate tool, and we'll talk about this. You might have to log into something separately. Okay, sounds good, but you need application management. What if they can't log in? What if they need to contact someone because they're blocked out or they need to reset their password? Who do they reach out to? And so even simple things like that sometimes would be outside of the scope of the care delivery team's normal line of thinking when they're going through different solutions, you know.
So Nate, you made a really good observation that indeed, you know, the survey is predominantly today answered by tech-enabled services companies. Although we see, you know, a lot of traction coming also from traditional healthcare providers in the webinars and subscribers to the newsletter. So CareOps definitely resonates there as well. What would you both, so, and it's right that traditional healthcare doesn't have any product managers, let alone, you know, a digital product team, right? What do you advise them if you have, you know, we have people in the audience from traditional care providers, how would you advise them in absence of a product team? Should they start hiring one? Or, you know, in absence of one, how should they tackle that role? And why is that role actually crucial, that product manager? Can't I use IT for that?
I'll jump in. Just the quick answer to that, Thomas, is I think it's a different mindset. It's blending. You know, CareOps is a good place to start in thinking about the life cycle model for care delivery. Is different than pure play technology, and it's different than the classically trained clinical care delivery. And so you might not need to hire a product manager right away, but just having your existing teams do some training or some advanced courses in product management might help to you know, flash a light bulb, and to which they could then branch out more deeply if it makes sense, you know.
That's a good answer. That's a better answer than anything I was going to come up with. My reaction was, it's been so long since I've been in a traditional healthcare system. I'm not sure I know how to advise them on how to improve their processes anymore.
Yeah,
but
it's
I think
like
we're
foreign concept, right? Totally foreign concept. You just have to understand that the product mindset exists, period. It might be totally off the radar for a traditional healthcare system.
Maybe, Tony, out of curiosity, so my big belief is that maybe in 5 years we will have we have like engineering team at hospitals, and we will have product teams. Like Providence is a good example. They have product managers. Bayada also, I think what you mentioned was like 2 years ago, started to hiring product managers. Like, what was the trigger to start hiring PMs internally? Like, okay, we now want to hire PMs. Like, what was the trigger event that made you decide that, and what is the benefit? And obviously this is a rabbit hole question, so feel free to just summarize yeah, what you've learned and the trigger that made that decision.
Yeah, I don't think it was a single triggering event as much as it was, you know, true strategy and understanding the market landscape, understanding where we're going, staffing constraints, number one. So there's no shortage of volume of patients in home-based care right now, that individuals that need the care, the shortage isn't really in finding enough caregivers. And so how do you naturally extend to different types of care delivery, knowing technology is going to play a bigger part with the aging population. And so realizing that we needed to get a little more tech savvy or risk being behind the curve, you know, in the long run.
Yeah, well, that's an important notion there, risking getting behind the curve with hospitals unbundling value-based care, with, you know, AI coming on the scene. The competitive field for healthcare provider has changed, right? As a clinician, you can now start to work in many different places than just in the clinic around the corner. And it's this getting behind the curve that is new for a lot of healthcare organizations. This is like a once in multiple generations shift that is taking place. And, you know, coming back to something you said in the beginning, it's, you know, it's these innovators that have got onto this and are already executing. And so that's where potentially the laggards might face difficulties. Let's move on to the next phase in the CareOps life cycle. So, you know, designing these flows is all well and good. We see that's on the up. We see that more of the core roles are getting, you know, pulled into that process to design the flows. There are tools in place, but what we're seeing is that, you know, despite a rise in implementation of flows, so we now see that more than 63% in, I think there it is, yeah, 63% of organizations surveyed have more than 6 flows implemented and actually live, and there's 45% who have more than 10 live, which is definitely an increase versus previous years. But what we see here is that this is still the minority of care flows that is live. There should be actually many more that are supporting care delivery. That obviously changes if you're providing specialty care versus primary care that is really broad. But ultimately, it seems that just having 10 care flows or less live is just not enough. Nate, in our preparation, you also mentioned that when you're using static tools, like a Visio and a flowchart hanging on the wall, it's hard to scale the number of care flows at your organization. Can you elaborate a little bit more about that? Is the actual what is happening in design, is that actually limiting the scaling of the number of flows in implementation?
Yeah, I think the way you implement your care flows has a lot to do with how many of them you can have live at a given time. Because if the care flows require a lot of if they create a lot of overhead and they require a lot of bandwidth from your frontline teams to implement, you're just inherently going to be limited in the number of them that you can roll out to people. Because like Tony was saying, if it relies on someone remembering to do something, you're going to have limited uptake, and you're going to have people like every time you encounter a situation, it's like, okay, now I got to go find the Google document that tells me what I'm supposed to do in this instance. And that's not a recipe for being able to do a lot of them, right? Because people have to know what to do, and they have to reference the material that you've given them. And so you can have flows that look like that, but you can only have a certain number of flows that look like that at any given time. And they might be early ones that you haven't had a chance to build out into your other tooling or something along those lines. Or maybe you're a brand new organization and you've just launched your MVP. Of course, you're not going to have spent a ton of time perfecting all your care flows. Oftentimes in MVP, you're going to have a basic idea of what to do and put really good clinicians on it to make sure that it happens. But as you mature, if you want to be able to drive more outcomes, if you want to be able to increase the number of care flows that your team is adhering to, I think you have to have some tooling that supports it day to day. Even things as simple as tools that deliver training in the moment to help people. But ideally, workflow tools that allow you to inform decisions and have branching logic based on what people are putting into your software systems that instruct them on what to do. That's where you really get leverage in driving decisions and driving care through the pathways that you want it to go through. But I think this thing about stage is important, right? If you're launching a brand new thing, don't expect to have 500 care flows built out. You have to match it to the stage of your organization.
Good point, Nate. I probably add, 500 seems like a lot. Just at a glance, there is a handful there that have a whole lot of care flows built out, which is great if you can use them. I think the only distinction I would add is probably, this might be an oversimplification, but at least for sort of long-standing health systems, you have your EMR care flows, which is different than your sort of ad hoc or best practice or care pathway care flows that might exist outside of the EMR. And maybe you need a different system, or maybe that's where you go back to reference files or PowerPoints or PDFs on the wall that you have to dig through. And so you might have better success if it's built into your workflow within your EMR, but there's a longer cycle to get it built out, get it tested, get it approved. There might be a release cycle. There might be multiple layers in there. And so depending on your vendor and who you're working with. And so it's like speed sometimes comes from the stuff you can control directly, but adherence might be harder than something that's forced through an EMR. So it's just something to think through,
There's an in-between there too, which is so for instance at Pear Team we've built out our own in-house care management platform, which we call ARC. It's essentially think of it as a giant workflow engine, right? The pathways are defined. It tells care team members what we expect to be done at different stages of the patient's care journey. And then we can we can design and create those workflows and show them to the care team at the stages that are appropriate for the patients. And it actually, like, ARC allows us to coordinate across organizations. One of the distinctive features of PAIR is that because we're doing so much in the way of social intervention for our patients are experiencing homelessness, have severe mental illness, substance use disorder, criminal justice system involvement. We're coordinating with a giant network of community-based organizations that participate in the social care of our patients. We're all involved in what we call our value-based enterprise, who contribute to the social care. And the tooling then allows us to collaborate across those organizational boundaries too, because we can use the care flows not just internally, but with our third-party CBO social service providers to get the patients the social care that they need. And so having that kind of tool, like, we can do rapid cycles on ARC that don't require us to go like get our EMR provider to change the way that they do things, or build out modules inside of the EMR. And so ARC is sort of like the puppet master behind all of this that can then we can then use the other tools within the flows that we've created in ARC.
So maybe one question that I have, so it was actually an email that I received on Monday. It was from a clinical operation person, or at least like director even, and she worked as a large home health provider as well. And so she screen shared what she has in terms of care flows. And so she designed, I think, about 100 different care flows, but it's all in their internal wiki. So whenever I'm a nurse, and it's virtual, so I'm a nurse, I see Tony, which is my patient, and you have hypertension. Then on one part of my screen, I see Tony, and on the other part, I see the care flow that has been designed by the clinical team, which is like written out Google Doc type of flow. And so I have a lot of like cognitive load that needs to happen. And she's been trying to sell to the clinical leader, so the CMO in this case, like, we need to fix this problem because we have more and more flows. It adds a lot of cognitive load, but they're not listening because they don't see this as a problem, and they rather spend their time slapping AI on stuff or buying fancy technology than fixing the processes that are like burning out their team. So maybe Nate and then Tony, both of you are like clinical leaders. You see the problems because you have also experienced the pain of not scaling this. But what advice would you give to those people trying to sell this as a problem to their leaders, but cannot manage to do so? Is it you cannot convince them and just let things break and let people burn out? Because I don't hope that's the solution. So what advice would you give to this person specifically?
So I always start with what's the business problem that you're trying to solve, and aligning the business problem with the clinical goals is the way to achieve the clinical goals. And so I guess my question for this leader would be, what are the business goals? What are the metrics that you think your organization could achieve that you're not achieving today because of the absence of this type of tooling? Because that's like ultimately the reason you invest in these things, is because you need to drive outcomes on something, right? And so, like, what are the outcomes? What are the metrics that you're going to use to measure whether you're achieving those outcomes? And then, like, what's the current status of the workflows that are meant to lead to those outcomes? And what's the adherence to those workflows? And if your tooling is essentially a Google Doc on the side of someone's screen, the adherence is not going to be that high. And in this organization, they may or may not even be measuring the adherence to their care flows. And so, but then you build the case around, well, if we had, this is just like sort of management 101. If we can measure our performance against these outcomes, if you can measure your performance on the processes that we believe will lead to these outcomes, then we can improve our performance on them. And if you don't have those tools, you can throw AI at it if you want to, but you're not going to deliver on the outcomes that you're trying to deliver. So and that all, like, you have to work back to your incentives, right? And your incentives, maybe we have to improve quality to hit our goals on this contract, and maybe we have to reduce total cost of care. In a fee-for-service thing, it might be about volume for revenue. You have to ask yourself what those goals are. But you should align all the work you're doing to those goals and then use that to build the case for what you're doing.
I don't think I could say it any better, Nate. I might just reiterate what you said and getting really clear on what's the problem you're trying to solve and what's the business value. Like you just said, it resonates with me, but it makes a lot of sense for, is it time savings that results in extra minutes that could result in seeing X number of additional patients per week, or, time savings in what you're paying staff, or there's got to be value that aligns with the organizational value, other than, I hate to say it, the hardest thing in care delivery is people will come up with really good ideas and we'll bring it to the team and say, hey, there's this great tool that will help to prevent falls in patients' homes. It'll help to stop people from falling, leads to injury. It could be great for our patients. If it doesn't necessarily translate to one of our key outcomes or measurables or value or time savings, or how does it pay for itself in a sense? You've got to convince the business people as well. And so the hardest thing is saying no to stuff that feels good clinically, but you can't directly translate to value. And it happens all the time, unfortunately,
Great stuff. I can already see some organizations, though, where the decision makers identify the problem as getting behind on the curve, as we mentioned earlier, and thinking that AI will put them ahead of the curve again. So the very act of problem definition is nice to call out, and it's definitely true. I agree with it, but defining problems at the right level is not easy in itself. It is a skill in itself that as an organization you need to get good at. Like, at what level do we define our problems? And because that's indeed one of the upstream activities you need to do, because it defines so much of the downstream solutions and implementation that you can drive. Let's move on to the next insight here. We've already touched upon it a little bit, right? Tooling to use these care flows in practice. What we're seeing is that 86% of care teams still have to rely on external tools to access care flows. So the EMR is more and more a tool where these care flows are being made available. We all know that EMRs in general are kind of on a trajectory to become more open and to have APIs that other systems can talk to either fetch data from or push some data or a task or whatever into that EMR. But still we see that as a whole, the digital document wins. And as Nate said, the homegrown system, which is very often a web application, is also a very strong contender there. Tony, maybe how is this solved at Pair? What kind of tooling do you have in place currently? And how does your digital product team deal with this constellation of tools today?
Yeah, we definitely have the constellation of tools. I won't deny that. I think it comes back to, for us, when you're talking about a scaled organization, one of the other options out there is to really move towards specialization to help control the variation or the inconsistency. What I mean by that is, like, for example, we have a technology tool that does patient risk stratification, like hospitalization risk stratification. It also flags for unusual utilization patterns, like, are we giving more than the typical number of in-home visits, or are we giving too few? So we might not get the optimal amount of care results. And so having all of our different hundreds of managers across 100+ locations log in, double check, toggle different systems, screen for these patients. There will be some that will understand the value, and will do it religiously, and there will be some that won't. And so how do you control for that variation? What we did is actually stood up a small, what we call care navigation team, is if you can define the value there and have 2 people, 3 people, 4 people who are solely responsible for that specific metric or that specific tool, you can then scale it across each of your locations, reduce the friction and the administrative burden at the frontline staff and the management staff at the individual locations, and do either some type of coordination node, press alert in the EMR, other alert systems, basically to manage by exception and say, hey, this patient has an unusual visit pattern. I suggest A, B, and C. Can you please take a look, versus trying to rely on every person to remember every facet of care or toggle between different tools. So it's something that might not be feasible for everyone, but if you can justify the specialization and there's an ROI to it, it's easier to control the inconsistency in a small group with clear expectations who are very specifically trained on a couple of different things, you know.
This is where having tooling and investing in the tooling that allows you to do this stuff really makes a big difference in your ability to scale and maintain quality at the same time. Because it's like you can train a small team to do something, and like most things should probably start with training a small team to do something and relying on them to just do it well. And you're probably going to train them on digital documents, right? And so like that's how most things should start. But when you want to scale to the point where you're doing this with thousands of employees, taking care of hundreds of thousands of people, you hope like by that point in time, if you're still relying on a digital document, you're probably going to experience degradation in the quality of what you're doing. And so like we've gone over the last 2 years at Pear, we've gone from being a ECM, enhanced care management, was a totally new program in the state of California, doing it with a small group of people down in Southern California, to being the largest provider of this benefit in the state. And I don't think we could have done that and maintained our clinical outcomes without ARC, the tooling that I've been talking about, where we've really defined these workflows. And it just makes your like, think about like we're onboarding hundreds of new staff members constantly as we scale this intervention. And you think about like your time to onboard a new staff member goes down as you like make the tooling easier for them to use. Your ability to reliably deliver the same results for each patient improves as you invest in that tooling. And so to me, like there's early on, organizations do things in hacky ways, and they should, but there's going to be a real difference in trajectory between companies that invest in the tooling to scale versus the ones that don't.
I love that insight. And I think what's very surprising is not surprising to me, but for others, is the organizations that invest in the tooling, like for example, Pear investing in ARC, are the organizations that invite or put second time or third time operators like you, Nate, in leadership positions, because they see what scaling looks like, and they will see what's coming, and they want to prevent that. So I think you sharing this is very important message that people should not ignore. And so, Anthony, you've been at Bayada 14 years now, and obviously you've seen the good, the bad, and the ugly as well. And so maybe for people listening, what lessons do you wish you had known when it comes to deploying care flows at scale that you want other people to know today as well, so they don't make the same mistakes you've made while scaling? Yep.
Yeah, it doesn't always go smoothly, right? You can try something with really good intentions. I guess number one is don't be afraid to fail. I tell my team that all the time, that as we're piloting, we're testing different things. If we're truly testing enough, not everything is going to work, and that's okay. And sometimes people beat themselves up like, oh, we thought we could add this technology and it just wasn't making a difference in our outcomes, or our frontline staff complained that it was too noisy and they were toggling in and out of too many different things. And so we get that sometimes, and it's being really sensitive to sort of not increasing friction in the system. One of the things we tried actually was like we talk a little bit about, I know we'll talk about like asynchronous contact for patients. But one of the things we stood up was a call center, which seemed like a really good idea, is having a specially trained group of individuals who could do outreach to high-risk patients, could triage any concerns that they were having, could see if there was any additional services that were needed, or if they could connect them with specialists or other care, and with really good intention. But what we found is the questions that were coming up and the issues that were sort of populated from the patient base, the call center people could not handle in the moment, whether they didn't know when exactly the nurse was coming out, or, oh, there was a change in medications, we better send a nurse out. And so it just sort of got sent back to the service team, the frontline team, who then had to synchronously, again, add some additional service, or had to reach out to the patient themselves anyway. And so where it was meant to reduce burden, it actually just kind of created another way of collecting information from your patients that got sent back to the provider, which they then had to act on. And so with good intention, it doesn't always work seamlessly,
I love that, Tony, how you put it, that you need to make sure that from an organizational perspective, you need to test enough and tell people that if it doesn't work, that's okay. I think in healthcare, there's very often this notion, we're dealing with patients' life. It has to be right all of the time, but then you're actually not pushing the envelope of, of what you should be doing. And so having that mindset of, let's test things. And that's what, by the way, something we see coming back again and again in the panelists that we have on the CareOps webinars. There has to be this mindset of, being able to test and organizational safety almost, that if it doesn't work, it's okay. We'll roll it back and we'll improve it. Because otherwise you get into this stalemate of we have to standardize on something that everybody agrees on will work. And that is just stalemate.
Yeah, even sort of the concept of deploying something that's not perfect and then refining and sort of working quickly. I guess as we talk about sort of the product mindset, it's not typical in healthcare where you want to get something absolutely perfect before you roll it out to a patient population because of fear of poor outcomes, where in some cases, like, it isn't necessarily going to make outcomes worse. Let's just give it a try and see. Worst case is, net neutral in some cases. So yeah, you can't run away.
Well, it's the perfect segue into the next insight here, which is, about measuring, right? How do you know that your care flows are hitting the mark, that they're hitting those metrics that have been defined by those business problems and then those clinical goals that you have? Now, the State of CareOps report unfortunately shows that organizations who measure neither clinician-reported outcomes nor patient-reported outcomes, so clinical outcomes that are either reported by clinicians or patients, so the number of that cohort has actually surged, right? So 10% did not measure either clinician or patient-reported outcomes in 2023. Now, in this year, that's 35%. So what we've also looked at, that this trend is actually more pronounced in larger organizations. So organizations who are scaling are actually measuring these patient or clinician-reported outcomes less, or at scale, less than the earlier organizations. Could this be a function of, when you're scaling, the actual business problem that you need to solve revolves much more around those operational efficiencies? There's obviously, renewed or no, eternal interest around profitability. We'll touch upon things like utilization rate later on. Is it a function of having this single focus on making the business work in a very complex healthcare setting, and that everything that is more clinical outcomes unfortunately falls off? What are your thoughts? How do you interpret these numbers?
I was hoping that what you said wasn't true. What you just said wasn't going to be true. I was hoping that it was going to be the small organizations that weren't measuring things, because I think it's understandable, and in fact, like, common and normal in the very early stages of building something that you just don't have that much measurement in place. I don't know what to make of the fact that it's larger organizations that aren't measuring patient-reported outcomes or clinician-reported outcomes. It makes me wonder, like, because even to your point about they're focused on scaling, like, I wonder what kinds of businesses they're scaling, because it's hard to imagine doing that in a value-based contract and not measuring outcomes in this way. And so I guess yeah, I sort of wonder, like, what are the incentives for these organizations? Do they not have value-based incentives, quality incentives, these types of things, or is it maybe just that that they are not measuring them to try to manage them? But I think you got to get yourself, like, well, maybe I'm making an assumption, but I think most of the people who are in early stage digital health companies, or even later stage but innovative digital health companies, are here because we want to make a difference and we want to improve the delivery of care in the health system. And if you're going to do that, you have to measure those outcomes, because otherwise, like, why are you here, and how do you know whether you're achieving your purpose? Growing the business is obviously critical to having an impact. But if you don't know whether or not you're making anything better for anyone, I sort of like ask like, why do you exist? Why are you in the digital health space as opposed to consumer technology or something? Oh, that's maybe a little maybe a little harsh, but that's kind of my feeling is like that's the purpose of these types of companies, and we gotta measure what we're doing and be good at it.
Yeah, this was very surprising for me as well. I think at least in home health, we're heavily regulated in certain outcomes that we have to report that CMS collects from claims data. There's star ratings, there's value-based purchasing. We have a standardized patient satisfaction survey that we send. It's pretty similar across hospital systems and acute care, skilled nursing and rehab facilities. And so I'm surprised that the number of organizations that aren't collecting some type of outcome data now. I would hope they would have at least a few KPIs internally that they're tracking along the way, you know.
Well, maybe it's again a function of that definition what an outcome is, right? Michael Porter, the grandfather or the godfather of value-based care, actually dubbed it outcomes that matter to patients. And I was having this conversation with the CEO of a very large ACO managed care organization, and there is actually a lot of criticism around value-based care or questions around is value-based care actually delivering on its promise. But the point I argued was that value-based care as an ideology still makes total sense, but it's the implementation of it, or the many ways that it has been implemented by, for example, CMS in the US and by different governments and organizations in other countries in the world. That's where it falls down, because ultimately that's where this new incentivization comes from. You need to hit these and these metrics, but these metrics are very often, so the quality metrics are very often just proxies for those outcomes that matter to patients, because it's obviously difficult to measure survival or quality of life if that's an outcome that only becomes visible 10 years from now. So is that maybe what's at play, that to the best of their abilities, CMS defines these metrics, but they are still only proxies for true clinical outcomes.
Yeah, I think you're totally on point there, Thomas. It's like they're choosing the best that they have with the data that they have available, and you have to maybe make some dotted line connections to show actual value for the consumer, which is not always the case. Some of it can be gamed a little bit too. There's some control within the organizations and documentation and other things, and so variation is out there.
Yeah, no measure is going to be perfect, and measures can be made better. No measure is going to perfectly capture what every patient wants, because we're all individuals and we all have different things. And so I've often asked the question when we're talking about value-based care, like whose values are we talking about? Because different people have different things that they want. But like across the population, across the health system, it's hard to argue with like, on average, we'd like better control of diabetes, or on average, we'd like more seniors to spend more days at home than in institutions, right? And that doesn't mean that like better control of diabetes is the right thing for every person. There are people who are at the very end of their life and they should be just eating whatever they want to enjoy, and there are people who need to be in an institution. But like in general, improving on this measure is better than on those measures as a population is better than regressing on those measures. And we as healthcare providers should take accountability and responsibility for improving on those things. And I think that's like the details of value-based care, I think it's easy to argue and quibble about, but like the long-term direction of where we're going, and that healthcare has to deliver value for society and can't eat our entire federal budget, like that has to be part of the conversation of where we're going as a country and a community of providers.
Great. We're coming up on the end of our time together, so we're going to go relatively quickly over the following sections. which is fine because there's already way too much talking and buzz around AI. But with the State of CareOps, we were absolutely interested to understand, where do these organizations currently see the biggest benefits of applying and implementing in AI? And it kind of comes back to the previous point, right? Instead of deploying AI, to improve outcomes, there's a very clear preference currently to deploy it to create administrative efficiency and cost savings. Maybe Tony, for you at Pear, for example, is it a hard no right now to touch anything patient or clinician outcomes facing with regards to AI, or how are you exploring that at Bayada?
Yeah, on the Bayada side, it's definitely not a hard no. We are exploring. We've been in there's so many new companies popping up, it seems like weekly, and so it's a lot of exploration. We're in sort of secondary phases of moving towards a pilot primarily focused on documentation capture for us. And so we looked at a lot of different use cases, a lot of different values. And so capturing there's a pretty big administrative burden in home health around documentation and data capture that we feel like if we could save time there, reduce friction for our frontline staff, that we could repurpose that in-home time into following care pathways and sort of the CareOps lifecycle piece. And so it's reducing documentation burden to improve focus on the patient and care delivery, but also hopefully reduce time. There's other cost savings that could come from it that could help offset the expense, but we are looking very closely at AI opportunities right now. So nothing piloted yet. There's a legal compliance, data storage, deep with the product teams, a lot of work to get everything sorted before we can jump in,
Yeah, I think we're all wrestling with this, and what's the place of AI, particularly like the LLMs that are the newest technology here, like where do they belong? The use cases around like an AI scribe to make documentation easier, searching charts to reduce burden of capturing codes and stuff like that. Having AI agents do phone calls, those all seem like things that are going to be happening at scale in the pretty near term. But I'm not surprised that like the clinical use cases are more limited, because I think all of us who are clinicians are trying to figure out like, what do you do with these hallucinations, and the fact that like this thing's gonna be accurate, super accurate 95% of the time, but 5% of the time is going to tell you something completely false. And I know that all the technologists are working on these models at the fundamental level to try to improve those things. But we're asking ourselves, what's the level of reliability and accuracy I need to put these into my clinical workflows? I think some of the more interesting cases might be things that don't rely on the tooling for decision making. But for instance, our team just showed me something around like essentially having AI summarize a patient's chart, because you've often got charts that stretch back 30 years, and your clinicians are limited in how much time and effort they can put into reviewing all of those things. And they're doing some interesting things with the models where like the model enters like the agent that searches the chart enters into a dialogue with another agent that checks it and forces it to link all the documents that it's citing. I think that improves accuracy and will end up being a useful tool for our clinicians. And then there's interesting work being done at places like Google around essentially like making an LLM a partner to a clinician and combining their two different types of intelligence to result in better care plans for patients. And I think that work's going to be really really interesting, and I think we'll see that probably sooner than most people expect today.
Okay, good. Well, with that, we're at the end of our hour. I want to thank Nate and Tony for the insights, the expertise, super valuable. Also providing a little glimpse of the very first CareOps conference that we're organizing in January. We're keeping that small for the very first one, but we're super excited to really bring people physically together. That hasn't happened a lot with CareOps since the beginning, because it was still kind of a child of the pandemic. So looking forward to bring together a group of like-minded people in January. The application for to be there will be launched soon by Rick and the team. So definitely everybody who was in this webinar will receive some more information about that. And then we'll close here, right on time. Thanks also to everybody who joined, and see you soon.
Thank you. See you in Nashville and see you at the next panel.
Thank you. Thanks,
Thanks for
everyone.
having us.
Thank you. Bye-bye.